ready? You got me running, you got me running, got me running. Shake it, shake it, shake it, baby.
I'm Meredith Hirsh.
And I'm Mike Chavez.
And this is Working Healthcare. Today, we're at it again, tackling one of healthcare's biggest challenges, the growing physician shortage, and how smart tech and new billing options can help close that gap. Did you know that nearly 30% of patients skip doses of self-administered medications? That's a serious drain on outcomes and provider time. At the same time, nationally, the average wait for a new rheumatology appointment is 6 months, delaying care and increasing burden. And over the past 3 years, EHR add-ons and plugins have exploded by more than 200%, signaling a clear demand for better tools for both doctors and patients.
Which brings us to our amazing guests. First up, Dr. Daniel Solomon, Yale Med, Harvard Masters in Public Health, fellowship at Brigham and Women's, and likely the longest research CV you'll find in all of rheumatology. He served as Chief of Clinical Sciences and Co-Director of the Center for Patient-Centered Comparative Effectiveness Research at Brigham, and faculty at Harvard Med since 1998.
Dan's been leading a game-changing effort, starting 7 years ago as an academic project that's now rolling out as MPro Health, a digital rheumatology tool embedded in Epic at both Mass General Hospital and Brigham and Women's, and recently launched on Athena Health as well. It captures patient-reported outcomes and seamlessly integrates them into the EHR. His recent study in arthritis and rheumatology, a mobile health application integrated in the EHR, showed dramatic improvements in clinical efficiency.
By implementing MPro, Dan was able to cut patient wait times in half, from 6 months to just 3. He shared that 60 to 70% of patients remain compliant with the app, sharply better than national averages. For providers, there is a way to add ancillary revenue through Remote Therapeutic Monitoring, a reimbursable service with Medicare paying between $19 and $58 per month, depending on the code and the insurer.
And joining him is Mark Elfers, CEO of GreenCape Health, a Naval Academy-trained aerospace engineer and former Marine officer. Mark brings mission-driven leadership and deep experience scaling health tech ventures, securing payer market fit, and leading strategy across digital health, biotech, and behavioral care. At GreenCape, he's focused on empowering clinicians and patients through connected platforms that support chronic care management services, including remote therapeutic monitoring and principal care management.
The big question, can MPro's model embedded in Epic and Athena work beyond rheumatology across other specialties? And can that help lighten the provider shortage, give PCPs and specialists more ancillary revenue, and deliver better access?
All that in under an hour. Stick with us as we dive into how MPro and GreenCape are reshaping care delivery, and how tech-driven revenue streams like RTM, PCM, and CCM work in practice. And finally, what this means for cutting wait times, boosting patient adherence, and fighting burnout.
Let's do this.
Dr. Daniel Solomon, Mark Elfers, welcome to Working Healthcare.
Great to be here, Meredith and Mike. Thanks so much.
Yeah, thanks for having us. Appreciate it.
So excited to have you. So Dan, I always like to go back, and I really want to understand, why did you choose to pursue medicine? And then why did you pick rheumatology?
Sure. As you'll hear from most physicians, I chose to go to medical school and become a physician because I enjoy being in a profession where I'm helping people, patients in need with healthcare crises or with pain or diminished quality of life, need a guide, need a physician who can help them navigate through difficult times, difficult waters. And in rheumatology, it's really a specialty about quality of life often. It's different than oncology or cardiology, perhaps, where they're dealing with quantity of life. I'm dealing with quality of life. Can a patient enjoy their life, enjoy their time with their family, enjoy and be a productive member of the workforce, of the larger community? I'm thinking about reducing pain, improving function through pharmacologic treatments or non-pharmacologic measures. And, I find it tremendously satisfying to be the physician that's helping patients navigate through difficult situations.
When did you realize you wanted to do rheumatology? Did you decide in medical school? Did you know for a long time?
Yeah, when I was in medical school, I had some great mentors. One of them was a rheumatologist who focused on geriatric rheumatology, so kind of improving function in patients with arthritis and other disabling conditions. And he really instilled in me a love of focusing on quality of life and focus on chronic care of patients who were disabled. And then as I moved into post-graduate training as a resident and then as a fellow, I saw that, rheumatology had a lot to offer scientifically, from, complicated inflammatory autoimmune conditions to just difficult treatment decisions for something like rheumatoid arthritis. And these were all interesting questions, interesting clinical scenarios that patients really needed an expert to guide them through. So medical school and then residency really convinced me that rheumatology would be a great profession for me.
And your career has been deeply rooted in research. I told you I've never seen a research CV longer than yours. I've heard about you in circles in the rheumatology world. Your name is all over the place. You were highly involved in the ACR journal. I do know that. I think you were the editor-in-chief. Were you not?
Yeah, no, I'm currently the editor-in-chief of Arthritis and Rheumatology,
Okay.
which is the premier ACR journal. I hand over the reins next month to Lou Bridges, but it's been 5 years that I've been editor-in-chief, and then the prior 5 as deputy editor. So I'm deeply involved in the ACR, American College of Rheumatology, and the journals.
So anybody in rheumatology definitely knows your name. Why did you choose to go the research route? Why did you not choose to practice more hands-on clinical rheumatology?
Yeah, so I do continue to see patients, both in the outpatient setting and the inpatient setting. So I'm an active clinical rheumatologist to this day. But somewhere during my medical training, I kind of caught the research bug and really enjoy thinking about issues that affect populations at large, not just one patient, one scenario at a time, but thinking about, the most effective treatments for rheumatoid arthritis, or how to organize care most effectively for patients with autoimmune conditions, is something that fascinates me and kind of gets me up in the morning and thinking and wanting to come to work. And sometimes the day-to-day managing of patients, a large panel of patients, can be much less intellectually gratifying. It presents a ton of challenges. Many of those, personnel and people management. The research piece really just gets me excited.
Okay. And I really wanted to dig in and find out about the rheumatology fellows. So my husband did his rheumatology fellowship from 2000 to 2003. So I've been out of that world for a little while. We have had rheumatology fellows rotate through our clinic, and I see a huge difference in what my husband went through 25 years ago and what fellows are going through now. What have you seen is the difference? Because we continue to hear work-life balance, work-life balance. I like to use the term that I heard recently, work-life integration. And that's what I keep trying to tell everybody. Your work can be integrated into your life. But what are you seeing as a difference in fellows now versus 20 years ago? Or do you not? I mean, you're at one of the most elite programs in the country.
Yeah, I mean, it's a good question. And I think that my experience at Brigham and Women's, which is really, as you said, kind of an elite research institution, I would say that over the last 30 years since I've been a fellow, that our trainees, our fellows are pretty similar in who I was 30 years ago. They're incredibly intellectually ambitious. They're rigorous in the way that they approach patient care and in their research endeavors, and they work their tails off. They while we talk about integrating work and family life, the fellows that I work with are work their tails off at here in clinical care and in research. It is true that we as a program spend more time thinking about making sure that our fellows have a life outside of the hospital. So it is something that we focus on, and that we think about a living wage, and we think about what their life's going to be like after fellowship, and whether they're suitable for a research career versus a clinical career or some other area of rheumatology. So I think that we've kind of grown to think about things more holistically. But in where I am, I would tell you that the fellows are hardworking and darn smart, and challenge me every day that I'm, supervising them either in the clinic or on the wards.
I just have a side question, though, and I want Mike to ask his question out of complete curiosity, because you talked about the fact that we need to pay them a living wage, and Brigham and Women's is in Boston, very, very expensive. When my husband looked at his internship, he was looking in Boston and Chicago, and I was just grateful we got Chicago, because I don't think I could have afforded. I couldn't afford Chicago, let alone Boston. So what are rheumatology fellows making these days?
Yeah, I can't tell you the exact wage, but it's a very it's I think it's like low to mid 60s as a first year fellow, and it gradually goes up. It's based on the postgraduate year. So if if they've done their 3 years of residency, then it's PGY4, and then there's some slight cost of living adjustment because they're in Boston. It's not. It's hard if you have.
Yeah,
I
was going to say 60 really grand in Boston is pretty tough. I think it pays for a parking spot.
That's. I mean, you're right. Boston is expensive, but having children that are immediately post college making less than that, they can live on it, but they live with a lot of roommates and they eat a lot of ramen. So
yeah.
So from what you've seen, are more fellows today pursuing private practice or hospital, or more so research? And what do you think are driving those decisions?
Yeah, I think undoubtedly there's less people going into research. I mean, our current administration is threatening to cut NIH funding, and people are nervous about the future of biomedical research overall. Again, at the Brigham, the people who are attracted here to do fellowship are research driven, and so many of them are still going into research. I think across the country that has diminished to some extent. I don't know the exact percentages that it's gone down. Is it 5%, 10%? More going into clinical care, more looking at careers that are non-traditional, not research straight up, not clinical straight up, but some sort of hybrid, or people going into administration, or people going into pharmaceuticals, or investments. Even people who autoimmune space is really hot in the investment world. So, more and more people are going into these areas outside of the more traditional work descriptions.
It's interesting that you say that, because now that I'm thinking about it, and Mike, I know you know the rheumatologists I'm thinking about down here. There are a couple I know of specifically in the area. Husband-wife rheumatology team, actually. The wife went into research first, and then the husband for a pharmaceutical company, and the husband most recently, I think within a year in our area left to work for a pharmaceutical company. There was a rheumatologist who was working at a local hospital, and she left to do concierge medicine. I can think of another female rheumatologist who retired and now works for an insurance company doing the audits, I guess, or the prior authorizations. And it just becomes so difficult in the private practice world, and they're scared of private equity, which we understand, that they just abort traditional medicine. What do you say to your fellows? Like, how do you teach them? Because you're obviously a mentor for many people.
Yeah. I mean, I stress the fact that being a clinical rheumatologist is a lot of fun. That patients, I have patients now I've been seeing for several decades that I know them much better than their primary care doctor, and it's a very enriching experience, kind of seeing them through the ups and downs of diseases like RA or lupus or psoriatic arthritis. So it's very satisfying, and the research is. I mean, over 30 years, rheumatology has really, undergone a huge shift. The kinds of drugs we use, the kinds of therapeutics, the organization of the practice, et cetera. So it's an exciting area to be in. Having said all that, I understand that people are interested in different ways to use their rheumatology training. So I don't feel badly for them. I feel like, we need more rheumatologists. Overall, we need greater access to rheumatology, which I know we're going to talk about. And this is going to mean changing the models of care, not necessarily trying to train more and more rheumatologists. We need to train more and more rheumatologists, but we need to do lots of things to make rheumatic disease care more accessible.
For people who aren't really familiar with the rheumatology world, if you can just summarize really succinctly, because I love that you said rheumatology has morphed and changed so much, especially with the biologics. And it really started, from my understanding, with Remicade and Rituxan, right, back in like 2003. For somebody who's not familiar with all of this, what are you seeing how you can treat your patients now in 2025 versus what was available when you went into rheumatology clinical medicine?
Yeah, so I finished my rheumatology training in 1998, and that was the year Enbrel came on the market, and Remicade came on the market, and Vioxx came on the market. Vioxx has, died an appropriate death, but the biologics, over the last 25 to 30 years have really brought in our armamentarium in, our most common autoimmune inflammatory arthritis, RA. But the biologic paradigm has obviously crept into lupus, vasculitis care, psoriatic arthritis care, et cetera. And when you have a broader treatment armamentarium, more options to choose from, it just gives the patient and the physician a lot more to do, to discuss, to understand. And when, option A and B aren't working, the good news is you have options C through E. And I always tell patients, it's the best time to be a rheumatic disease patient now, because we have a lot of hope and a lot of optimism about finding treatments that are going to really put your disease in check, whether it goes into remission or it's just you have very low disease activity. You have a really good chance of leading a very full life. But there is some trial and error in how we find the right treatments for the right patients.
I want to jump over to you, Mark, because I think your background is fascinating. I love when I meet people who were a part of our armed services. So I want to thank you for that first and foremost. I don't know how you sit in a Navy carrier for as long as you do, because I don't think I could handle that. They paint them green on the inside for calmness, right? Did you know that?
I've never heard that.
That's not true.
Oh man, I thought that was.
Everything's gray on the inside.
Don't take away my thought process on this. No.
I mean, I like that idea. I think we could run that experiment.
I think we should. I thought the inside of submarines are green.
Yeah, that's not true either.
Okay.
I spent about 3 weeks on a submarine one summer at the Naval Academy, and it's incredible because we submerged in San Diego, we reemerged in Seattle, and it is
Wow.
incredible to think of few thousand mile journey, and we did a bunch of stuff while we were under. But just to pop up and be like, okay, that is incredible from a technology perspective to get this giant boat from here to there completely underwater and super quietly. So, yeah, I mean, it was I really felt drawn to service. I was grateful to be allowed to attend the Naval Academy and then become a naval aviator, fly with the Marines, and spend my first chapter there. So I feel really fortunate to have been able to participate in the Marine Corps like that.
I do know once a Marine, always a Marine. That's what my Marine
That
friends
is a
say.
thing. People do say
see?
that for sure.
Yeah.
I got one thing correct. So let me ask you. You started out in the U.S. Naval Academy. You studied aerospace engineering. I'd really love for you to walk us through your journey and how you decided to create GreenCape Health just last year.
Okay, yeah. So I mean, as I approached the end of my service with the Marines, I mean, my wife and I had 3 daughters, and we lived all over the planet. We lived in Italy and Okinawa, and I served in Iraq and Afghanistan and all over the U.S. And we were just we had done our time, and we were ready to go do something else. And I think my draw to serve the country through the military and through the Marine Corps had slowly morphed into this pull towards service, towards people. And I in my time in Iraq and Afghanistan, I saw that the world is a pretty big place, but we're all very much the same, the same kind of humans, no matter where we live. So as I was thinking about next careers, I had the fortune of knowing a handful of folks at Amgen, and I got to meet those guys and a good group of guys in their biosimilars team who were making biosimilars of Humira and Remicade, and I was able to join them and start to learn biotechnology. I kind of helped lead the global marketing team, and just was able to learn a lot from a lot of great mentors and a lot of great professionals at Amgen. Just a great company. I can't say enough about it. I left to join a prescription digital therapeutics company. We're making mobile applications, FDA approvable, for patients with cancer-related psychological distress. I was there for 3 years, and it really captured my fascination about this idea that technology can help improve the patient experience and multiply the impact of medical professionals like that Dan and was just talking about the fellows. You've got a handful of fellows. What if they could do 10x the work with the right amount of digital tools and the right digital tools? And I left there I left Blue Note Therapeutics to create Elevate Therapeutics. We were a digital palliative care company. We started with 2 docs from MGH that had created some digital tools for palliative care. And we met an investor with a much better idea and a lot more money than we had. So we traded our IP and some of our employees to create a new end-of-life service company. And at about that time, I met Dan. I went back to the innovation team at MGB and said, hey, is there any cool tech that might be ready to spin a company around? They said, actually, Dan Solomon just finished a study. It looks really cool. It's this mobile patient report outcomes platform integrated with Epic. Could really help. And I was like, great. Will anyone pay for it? Could this be a business? And we did about 7 months of research, talking to community folks, the people that were in Dan's network, and it seemed like there was a signal here, not only to improve the provision of care and the model of care by remotely monitoring patients in between the face-to-face visits and allowing a practice to care for more patients with the same number of folks inside the practice. But there was this thing called RTM. Maybe there's an ancillary service that could be built for it. And there was this thing called MIPS. Maybe there was a way that these outcomes could improve the way a practice scored in their. So we said, hey, it looks like there's a thing here. We went to the Brigham. We asked them for a little bit of startup funding. They provided us a non-dilutive grant that allowed us to kind of get the product off campus. And we founded the company in August closed our first 2 customers in December, and we are off to the races.
I love that story, and you're definitely the business head on this. And Dan is that researcher understanding rheumatology. I would love to understand, Dan, what your light bulb moment was. Like, why did you even create something like MPro? What ignited that desire, or what problem were you trying to solve 7 years ago when this came about?
Yeah, sure. So MPro it's a digital health platform that for most patients, it presents as a mobile health application, so an app that you would just download on your phone or tablet, and it allows patients to report their symptoms using patient-reported outcomes (PROs), therefore MPro, on their as their application, and they report them daily, every other day, weekly to their into the app, and the app then transmits that information to their clinician through the electronic health record. Why we ended up going this direction, really, I can remember conversations that I had 7 years ago with other clinicians, other researchers about the advent of digital health technology and how that was going to impact rheumatology. And we all agreed that PROs, patient-reported outcomes, were so important for us to be aware of and look at for our patients in rheumatology. However, we were doing a poor job at that. We didn't have good tools between visits or at visits to allow patients to give us that information in a structured, systematic manner. And we quickly realized that digital health technology could potentially solve that issue. And so we kind of, through some prototyping, we kind of developed the first iteration of MPro. And that was done with one of my colleagues, Yvonne Lee, who's since gone off to Northwestern. And we tested it. First, we said, let's just try it in rheumatoid arthritis, where there's a lot of patients at the Brigham. We kind of know what PROs are most useful to them. And so we created an app with a software developer for a collection of these PROs for rheumatoid arthritis patients. We tested that app, that digital health platform, in 100 patients over the course of a year. They liked it. They used it, again, about 70% of the time. So the adherence was quite high. And they were happy because they felt like they could see their disease developing and their symptoms over time. And that gave them a sense of control, confidence, something that we would describe as self-efficacy, kind of the confidence to understand and manage your disease. And we know that's really important in patients doing better. But the missing link was trying to give the data to the clinician so they could use it in their typical clinical workflow. And so that took a lot of iterating with my colleagues here at the Brigham and trying to figure out how to do that most effectively, whether it was a dashboard or integration within the EHR. And eventually we figured out how to integrate it in Epic, which is the electronic health record that we use here at Mass General Brigham. And that was achieved about 3 or 4 years ago. And then we ran our last study in rheumatoid arthritis. 150 patients used it for a year. We compared them to matched controls, and that gave us a lot of confidence that this was a really useful tool. And that's kind of when I met Mark and we started thinking about taking it off campus, making it more of a commercial product.
And I always think it's interesting to look at the business side versus the clinical side, because Mark, you and I have talked about how this could be a value-based care model, because it's not really used in rheumatology right now, value-based care. And you could potentially get higher reimbursement from insurers if you're showing better outcomes. But I think Dan was using it more on the, I want to say, research side, clinician side, the truly just not thinking about the money side, but looking at outcomes and seeing how we could actually assess if patients were doing well on their medications. And I always am in meetings with physicians and they think I'm like the big bad guy because I'm looking at it from the business perspective. But if you can then flip it over and say, but look, it also actually helps patients. You know, if you're doing the right thing for patients, that's the great benefit, right, to everybody involved.
Sure.
Yeah, I think in this case the circles are closer than they might initially appear, because if a guy like Dan sees 25% of his patients and those patients are completely stable, look, Stelara works, Humira works, MPro works, it could work for decades, and 25% of those visits are stable, and they catch up about grandkids, and they catch up about kids and the terrible Boston weather, or the strikingly infrequent beautiful Boston weather. It's a great visit, except it didn't need to happen.
Right.
And if there's a 6-month wait list and there's people wrapped around the building waiting to see a guy like Dan, from a business perspective, there's leakage there. Mm-hmm. And those customers will find a way to find some relief. So if Dan can say, hey, I got 25% of my patients that could be delayed, and I could say, hey, maybe I don't need to see patient Mark every 4 months. Maybe I need to see patient Mark every 8 months. That gives me another 20-minute slot to either see my flaring gout patient, or my patient with vasculitis, or my patient that, the first drug just didn't work and they're having the predictable, sometimes adverse events. Or I can pull people from the line that's wrapped around the Brigham and get them in early and have them as a stable customer base. I think about it like that. So I think, when Dan's thinking about why am I seeing stable patients and having even now a 90-day wait list, we could do better with a tool like that he created. So I think there's a much closer overlap than other things that could just say, hey, this was interesting immunology science that got published, but is there a rheumatologist in America that's going to use it? Maybe not. This thing has, I think, an opportunity, but I'll let you all, Mike and Meredith, maybe push back on that from a community. Is there what's your take? Am I drinking my own Kool-Aid here?
No, because I actually think this is really great on a quantitative side, right? Because there is true data and information. So instead of just saying something generic and saying, okay, the insurance company requires us to monitor you every 3 months or every 6 months, or you need a new PA, a prior authorization, and I want to see it. You actually are getting quantitative data and you can submit that to the insurance with the PA, as opposed to saying, oh, we have to physically see the patient. I interviewed Jin Lee, and she has a rheumatology first clinic out in California. She sees a lot of rural patients. And so in order to eliminate this wait, they have a 9-month wait in that area. She has been able to implement a virtual first clinic where it's like, do you even need to see me or not? Okay, you have a positive ANA, but really? Do you have lupus? I mean, is that the reason? No. Like, there's something that we can do virtually. Now, can you give a joint injection virtually? No. You need to go see the rheumatologist. But if you need to do something where you don't have to feel the joints and you're just, checking on the grandkids, I think it can definitely be something that's utilized. And I'm hoping that rheumatology catches up with the rest of medicine if we can look at something like value-based care that actually helps patients. That's my biggest challenge, is a lot of these MIPS and value-based care models are stupid and they really don't move over to helping patients. But my whole goal is, if you do the right thing and you're helping the patients, you're helping the doctors. It's one and the same. I would love to hear Mike's perspective, especially I know that you have a lot of questions on the app side, tech side. Mike's like a techie guy.
There's been a rise in these mobile health apps, right? So how has that rise in the mobile health apps changed the landscape of managing diseases like RA?
Sure. Yeah, I mean, I've done a fair amount of searching of apps as we are have been developing ours, I spend a lot of time looking at other apps, trying to understand what are interesting, functions of those apps. I'm going to tell you that I've reviewed pretty intensively a lot of the RA apps and the psoriatic arthritis apps. I've signed up for many of them. I download them. I respond to them. And almost none of them are bilateral. They do not allow the clinician and the patient to communicate. They allow the patient to track some of their own symptoms sometimes. They allow them to get inspirational articles about diet and exercise. That's great. But it's this ability to track your symptoms using validated patient-reported outcomes questionnaires, PRO questionnaires, that are then uploaded to the electronic health record, and the doc knows how to use those data to then more effectively manage the patient. That's the secret sauce that we've developed with MPro. And on top of that, we give the doc suggestions based on the data. So we don't rely on the data sifting through reams of PRO results. We do that for the doc, and we give them suggestions when to see the patient based on those data. So
when you say we, describe the we. Who is the we that is giving these suggestions to the doctor?
Yeah, the we is the app. The we
Okay.
is how the app's been programmed. The app, we have a software development team. We have a chief technology officer with a lot of experience. And then, I've done umpteen focus groups with clinicians and patients. So everything we're doing is iterative and based on reactions that we're getting from real patients and real clinicians, not just a nifty idea that a technologist thought up. So I agree with you, Mike, that there's a lot out there, and it's great that people are trying to develop these ancillary products. I just have really seen almost very, very few that allow this kind of bilateral communication using kind of an evidence-based approach that is actually, we've published half a dozen papers on it. So it's not as if we just made this up and said, this is a great idea, why don't you use it? We've shown this in a lot of published research, which is really unlike anything that's out there. I mean, Mark, I don't know. What do you think?
I think, Mike, I think this is a great question, right? Because you could jam a couple of super smart engineers into a garage, feed them ramen and pizza for 3 months, and they could come up with a rheumatology app. They'll Google 100 things, they'll use AI, they'll try to get smart on things, and it will ask questions, and maybe it'll run some PROs. I think the difference is when you go to the market and you talk to providers are used to evidence-based solutions that they want to give their patients. So when Dan and I show up to a rheumatology practice, they're like, and it doesn't mean they're like, Dan built it and it was studied at the Brigham, so I'm buying it. They're like, okay, I will take the call. They still may not buy it. They still not be interested in integrating it. But I say this from experience, when you don't have the research and you don't have the rigor and the science behind your platform, you're going to struggle to get uptake in the market because just the evidence-based bias that clinicians have on purpose, and they're raised and trained like that, matter. Now, I will say, and I'm thinking back to my time at Blue Note and Elevate. If a technology team says, hey, I want to go into rheumatology and I want to find rigorous researchers that are thinking about these problems, I think they're findable. And I think in the time that Dan and I have been working, a handful of teams have said, hey, we're thinking about building a thing. It looks like you built a thing. Could we work together? And that's what I did at both of my other two companies. We sought out people that published multiple papers and said, you've been thinking about this, you've been building these things. Will you help us not mess ours up? Because left to our own devices, it will not be usable. Mike, I feel like I've talked
Yeah.
a long time
No,
there. Bring me back home.
Yeah, it sounds like beyond just the evidence that you talked about in the data, using it as a practical tool via that line of communication like Dan talked about with the provider sounds like an additional differentiator and really, like Dan said, the secret sauce.
Yeah, I think the practice, and we talk about this all the time internally, that the practice either has to be able to use this platform to make money, save money, or save time. And if your platform is not like soaking up time out of that system, out of that practice, or helping them make money through ancillary services, but there's someone like Meredith who on purpose, her purpose in the practice is like, yeah, but does this thing make money? Or is it just another gizmo that I'm going to ask the team to do? And if the answer is like, well, in this study, it helped like 2/3 of patients incrementally do well, you're like, okay, I want that, but I'm a business and I have to be focused on being able to generate profit margin, or else we're going to go out of business, period.
Right.
And then no one gets scared.
And you have to find the problem, right? Every product or every business model has to solve a problem. And I say that to my students all of the time. They come up with ideas. I'm like, but what are you solving? Like, what problem are you solving? And obviously, Dan, in clinical rheumatology, knows what problem needs to be solved. I'd love to ask you just the question, what percentage of rheumatology patients are stable on their meds?
Yeah, so we know this from the studies we've done in rheumatoid arthritis. In autoimmune inflammatory arthritis, it's the most common reason people are seen by rheumatologists. About 1/4 of visits are for patients that are stable. And when I say stable, we define that based on like the first month they're in using the app. We call that the baseline period, and then we compare future periods to that period. So it means their symptoms are basically stable. Does it mean they're always in remission? No, but they're stable on their meds. Sometimes they're stable and they're unhappy on their meds, and they want to have a conversation about changing a med. So not every stable patient should be canceled or delayed, but if you have that information, you can offer, the doc knows the patient, can look at the data, and then, the clinical assistant, this is what I do, is I forward the message to my clinical assistant. I say, Mrs. Jones is stable, doing well. Ask her if she wants to push her visit out 2 or 3 months. And then it opens me up for other visits. And again, as Mark said, that allows urgent patients or patients on the wait list to come in.
So this is my side consult. I was once told that being stable as a rheumatology patient, you're not going to get 100%, but the most you're going to get is 90%. 70% is really what stable looks like. What does that look like to you as a well-versed, very educated, experienced rheumatologist?
So when you say, what does it mean to be stable with RA?
Yeah.
Is that what you're asking?
Yeah, I guess so. Or psoriatic arthritis, because you're still going to have pain, right? You're not going to be 100%.
When I say stable, look, if you're in remission, you're in remission and you have, almost no symptoms. If you're in low disease activity, you have some low, level of symptoms. And many of my patients, some patients are in remission. Many of them are in low disease activity. Some are in moderate or high. Some patients in moderate, low moderate disease activity, they're like, this is what I've been for a decade. I have disfigured, I have joints that don't work normally, and I'm not ready to get a joint replacement. So I'm going to live with some level of pain, and changing DMARDs isn't going to change that. So if patients have had damage to their joints, they might have a pain level of 3 or 4 that is not going to be improved by often by altering the DMARD. So I think your point's well taken, that it's not like stable patients are all in remission. They're like, some of them are, but lots of them are in low disease activity. Some of them are in moderate disease activity, but they say, this is what I've been in for a decade. You've changed the drugs twice, that didn't change anything. I'm happy here, and I'll go on with this. And that's the changing expectations over time. Patients learn to live with their disease. Some patients are impatient and want to be in remission, and some patients are never going to be in remission.
So how do you reimburse the medical practice? This is my business question for something like MPro. So we talked about remote therapeutic monitoring. We talked about principal care management. We talked about chronic care management. So somebody listening outside, I'm hoping that this is transferable at some point to other specialties, right? It allows you to understand what is available. But before I get into that, let's talk the money side, because we're always looking into ancillaries and ways to compensate physicians, because we all know that every year physicians are getting cut and cut and cut for reimbursement. So this allows Dr. Solomon to be able to see the patient. Who's monitoring what MPro, the data that MPro provides, and then how is their reimbursement?
Yeah, I mean, the monitoring of the data, the way that we've set it up in typical commercial practices, community practices, is that there's a dashboard that often a non-MD monitors. So a medical assistant or an NP or PA.
So you could have an MA as opposed to an NP looking at this data. They're qualified enough?
Oh, absolutely. I mean, this is not rocket science. It's looking at patterns. And once, somebody has some experience has spent an hour with them looking at the data, they get pretty facile with the data and the dashboard. And it's, oftentimes it's like, I want to know if there's this sort of a pattern, but the platform also triggers alarms. So it's not like we're waiting on someone doing pattern recognition. The computer does the pattern recognition, sends an alarm to the practice on the dashboard or through the EHR, depending on if it's integrated in the EHR. So those data are being monitored. And there's money to be made by doing that remote therapeutic monitoring, the RTM. And I can let Mark speak to the details there.
Yeah, talk to me, Mark, money man.
Yeah, I think there's three buckets of value that we talk about for the practice, and RTM is one. But I think the very first is managing more lives with the same number of folks. And if you're able to, like Dan had described, be able to, with data, delay a chunk of those visits. And let's say it's 25% are stable, but only half of them wish to be delayed, or only half of them are able to be delayed because maybe there's the drug they're on, they must be seen, or their labs don't support a delayed visit. So if 12% of patients could be delayed and there's more time, then newer patients are more fiscally valuable, and sicker patients are more fiscally valuable. So you bring a sicker patient in or a newer patient in, you're going to make more money. So managing, instead of, let's say, a very busy full-time rheumatologist sees 1,800 patients a year, if that doc can see 2,000 patients without hiring another APP or not hiring another MP or PA, there's a lot of additional revenue for that person. So that management of more people with the same number of, or more patients with the same number of folks with this bit of technology, we think there's a lot of value there. The remote therapeutic monitoring essentially goes like this. The first, when the patient gets onto the platform, CMS and a handful of other payers at Blue Cross Blue Shield all have policies here. The practice is able to bill that, and Mike mentioned, I think that first like $19 payment. The second code says, hey, if the patients have logged data on 16 of the previous 30 days, it's not calendar months, which of course doesn't make anything easier, but 16 of the last 30 days, then you can bill a 977 code. So that just says if people are using this platform, then you can bill that 977 code. That's about a $38, $39 code. And then if you're looking at that data and you're managing that patient using the data, and there's a one-on-one interactive communication required for 980, that's about that $50 code. And then if you have another 20 minutes of work. It's not a 20-minute conversation, but it's 20 minutes of work reviewing all of this stuff and actively managing that patient. There's another code, 981. So those 4 codes are available to help augment the practice and what they're doing and reimburse the practice. And then finally and I think this is less tested, like we've been in the market since early this year, so we don't have enough data to submit anything to MIPS. We probably won't have any of our customers will have enough data to support the MIPS, but our assumption to them and our working hypothesis is if you can provide outcomes data via maybe it's a pathway agreement with your regional blue, or it's MIPS, or you are involved in an ACO and your primary care ACO wants to include you as part of a specialty network. There may be additional value there for you to leverage. I think that's an assumption. We've shared that assumption with our customers. They said yes. We just need to have more patients, more data. Right now we have dozens of patients and weeks of data. We need hundreds of patients and months of data, I think, to be able to test that hypothesis more definitively. But I'll pause there. Meredith and Mike, what questions?
Is the model scalable across specialties, or is there unique factors in rheumatology that make it a good proving ground?
Yeah, it's
I
a
love
great
that question. I just want to say, Mark, because I'm going to piggyback on it. And I'm going to say, really, value-based care isn't used in rheumatology right now. And so I know people listening are in other specialties. And so I'd love to know how you scale this.
Yeah, so I think, if we zoom out, the problem is too many patients, not enough docs.
Yeah.
And the gap is accelerating.
Yep.
So when you have a platform that Dan built and studied that provides a conduit between a sick patient who's seeing a specialty doc and that specialty care practice and say, I can help you manage those patients in between your face-to-face visits, I can, instead of I'll remove rheumatology and say, talk to me about oncology, talk to me about respiratory disease, talk to me about gastroenterology. Now, not every one of those ologies has an RTM-like mechanism. So people may say, well, you may not be able to bill specifically for RTM, but managing more patients and improving outcomes, especially in those areas that are value-based, are really is doable. And then when we go all the way towards the approaching end of life, where there are capitated models, and the hospice Medicare benefit is, it's about $200 a day per patient per day, that the practice must use that to provide all of the care, period. You can see where practice would say, hey, this opportunity to track how people are doing in between their face-to-face nurse visits with their hospice nurse through routine home care, there's real value there. So I think it scales, and we're testing a couple of hypotheses in a couple of different markets now.
What is the resistance by doctors? It sounds so great. Why would doctors say no?
Yeah, let me ask you, Meredith. What do you think the resistance will be? Mike and Meredith, you guys.
Oh, I'm asking you. I'm not working in my head going, what is the cost, right? And making sure it's new technology. And rheumatologists, I swear, are not the ones who like change. Sorry,
right.
But that's the truth, right?
There's a lot of possibilities.
I like that Dan is nodding his head. Our listeners can't see this, but he's very vehemently nodding his head. Rheumatologists don't like change.
Yeah, I mean, I think doctors in general are kind of, Luddites. They're resistant to doing anything new and different. They never learned about this in med school, and now you're telling them to use some technology. It's like everybody uses apps. Every doc has an app on their phone, so it's not really new. It's so easy to do good by your patients and do well by your practice, but it's really hard to convince people to change. They're feeling under the gun. They're feeling a lot of pressure just to kind of keep their head above water, and now you're adding something else to their daily routine, and even if it's 5 minutes, it sometimes feels like it's too much. So it's been an interesting conversation. I mean, Mark and I have had this conversation with dozens of practices, and some of them are excited, and those are our customers, and some of them are excited and they're nervous to do something new, and some are just nervous and there's no way they're going to do something new today.
I think it
I don't know,
takes,
Mark, what do you think?
well, I think it takes going to somebody like Mike and going to somebody like me and going to somebody who has a big mouth, right, and wants to be able to like save the practice. But that's what it takes, right? Because it's funny, I have all of my providers and my leadership team fill out something called a DISC assessment, and they all rank high on S and C. Like the only one who is D is my husband, and I didn't realize he was a D, but I said, that explains a lot in our relationship. D is like demonstrative traits, but mine is higher, so I told him I had to win. And then I is interpersonal skills. And we only have one provider. By the way, this was out of 10 that filled this out. One that had a high I, and he's our nurse practitioner, and he has high interpersonal skills. The rest, all S and C. What is S? Stability. What is C? Compliance. And you would think that going to med school, right? They're high S's, they're high C's. They like stability, they like compliance. Who else is going to school for 13 years plus, post high school, except for a rheumatologist, and maybe all of the other high S's and C's. So I think it really takes going to the business side to ask, but I promised that I would answer all of these questions in under an hour. So I would be remiss if I didn't ask and finalize this with, you could change one thing within the American healthcare system, Dr. Daniel Solomon. What would it be?
I think that, to be honest, it's a kind of a simple one, but it's really putting patients first. I think that there's so much noise in the healthcare system that's about the hospitals and the insurers and the health systems, that it does not really put the patient at the center, and next to the patient is usually the clinician. And I think that's kind of the root of, that's at the heart of what's going on in the medical care encounter. And I think all these other issues start to get heaped on top of it. So that would be like the top goal. And the second goal is to think about how to create a system that allows that relationship to be paramount. And that having the system facilitate that is part of what MPro does. It facilitates the doc being able to care for the patient in a longitudinal way using data. And that's really what we're about. But the number one thing is to make sure that the patient is at the center of everything we do.
And what about you, Mark Alfers?
Thanks for that question. And every time I listen to Dan talk, I'm always like, oh, that was super smart. I really like that answer. But I think for me, I think there is a need in our healthcare system to recognize the importance of behavioral mental health. And I think there can be stigma and fear around when folks say, hey, I'm really struggling because like Americans are strong and Americans want to be seen as strong and Americans don't want to be vulnerable. And especially guys do not want to say, I'm really struggling right now. And this has been a really difficult time. And I think it's tough for us to say that aloud to our care teams. And it's even more tough for the care teams to actually do something once they have that information. So I think there's a shift, and I think digital helps us here as well, because digital agents can help us have some of those conversations in a way that it's difficult to have in person. And I hope that was succinct enough.
No, I
Meredith
loved it, especially as a Marine. Once a Marine, always a Marine, but as a strong naval officer, as a Marine, and being able to express that mental health is so important. I would 100% agree with you. We recorded an episode already talking to, and we haven't launched it yet, but it's launching very soon, with Wendy Dean. And she is a psychiatrist, and she talks all about that. So I thank you very much. You're wrapping up what we actually talked about a few episodes ago. So
cool.
Thank
both
you.
those answers.
Dr. Daniel Solomon, Mark Alfers, thank you for sharing your solutions for fixing our American healthcare system.
Thank you.
Yeah, thank you so much.
To everyone listening, the full video of this episode is now live on YouTube. Just search Working Healthcare and hit subscribe so you don't miss future interviews, short clips, and behind the scenes moments. And if you've got a question, an episode idea, or someone you think that we should feature, drop us a line at meredithhirsh.com.
And if this conversation hit home for you or made you think a little differently, don't keep it to yourself. Share the episode, tag a friend, or post it on social media. You can follow us at Working Healthcare on Instagram, Facebook, YouTube, and LinkedIn. That's where we keep the conversation going between episodes. The more voices we bring into this space, the more momentum we build. Because change doesn't start with a policy, it starts with a conversation, a real one, like this.
New episodes drop every Tuesday, and trust us, you don't want to miss what's coming next. I'm Meredith Hirsh.
And I'm Mike Chavez.
Tune in weekly as we explore the inner workings of healthcare.
You ready? You got me running, got me running. Take it.